Hmm. Okay. YouTube. Hmm. Hi, good afternoon, everyone. This is Dr. Vamsi Krishna. Today we'll discuss about the neonatal upper airway abnormalities. Normally, the majority of the respiratory distress problems in our newborn period are secondary to the respiratory distress syndrome, pneumonia, TTA, and certain cardiac malformations. There will be certain difficult cases where we may have find that the X-rays are normal. Still, the baby might be requiring prolonged oxygen supply or might be having the different kind of sounds called stridor or wheezes. So, in these conditions, we should think of beyond the normal things that can be the airway abnormalities. So the upper airway usually extends from the nasal aperture to the subglottis and can be actually the multiple sites of congenital malformations. That can be lead to either anatomical or a dynamic functional obstructions. So this can lead to severe respiratory distress in these babies. We need to have an early diagnosis and we should have an appropriate management. So when compared to the adult airway, the neonatal airway is quite different. So we can see that neonatal have a large skull to the body area. So in fact, it's around the skull to the body is around 19% compared to the 9% in the case of the adult. They have the large cranial wall to the face ratio. So all this lead to pushing the head and neck into the flexion posture, which itself can lead to the dynamic obstruction at the upper airway. The tongue of the neonate is relatively large compared to the small oral cavity. So it occupies the significant proportion of the oral cavity and spaced a bit posteriorly into the hypopharynx. The laryngeal inlet is actually angulated anteriorly into the base of the tongue. So your tongue is big behind and just above your laryngeal inlet. They all made these things a bit difficult for the airways for the newborn babies. And compared to the adult or a pediatric, the epiglottis very longer, floppy, and usually is of an omega shaped or or inverted U shape. The narrowest laryngeal portion in the newborn baby is the cricoid cochlea compared to the adult where they have a at the glottis. The aryepiglottic folds, which are connecting to this arytenoids to your epiglottis, are very closer to the midline and they're very floppy and they may ups to the cortex. When you can see the laryngeal cochlea are very soft, you can compress them easily. So any external compression because of your dry dressing or any other external application can lead to this gateway collapse. So these are all the anatomical differences of the neonatal compared with the adults. So this is an epiglottis of the newborn period. We can see this large soft epiglottis which is in the U shape or omega shape, and we can see these aryepiglottic folds which itself are very soft, fluffy, and they're covering your vocal cords. Airway is much prone for the dynamic collapse, and any anatomical variation can lead to significant airway obstruction. Also, we know that the radius of these airways are much smaller, so any small narrowing because of the anatomical or either because of the another issues like your secretions, like your kinds of any other things can lead to the r to the power of 4. The resistance will be that in inversely proportional to r to the power of 4. So even small changes in the radius can increase the resistance by 4. So usually the neonatal upper airway abnormalities can present most commonly with the stridor. Okay. The most common other abnormal symptoms and signs are the cyanosis, apnea, dyspnea, and retractions, hypercapnia, difficulty in feedings. Sometimes we find the babies who might have certain amount of respiratory distress, but they're not growing good. They can have a difficult feeding. They can have recurrent episodes of vomiting. So all these can be indirectly suggest of the upper airway abnormalities. The cry can be abnormal when the glottic and subglottic area. So recurrent aspiration because of narrowing of airway can have the cough at any point of time. So the neonatal upper airway abnormalities can be broadly classified into nasal and the nasopharyngeal lesions, oral and oropharyngeal lesions. The nasal nasopharyngeal lesions are quite different. Cornal atresia, the narrowed apertures, and any oral lesions can be your epignathes, or it can be lead to any kind of other oral lesions. I'm not going into the depth of the nasal oral lesions. I want to give my topic more to the laryngeal lesions, which need to be addressed more prominently. So the laryngeal lesions. So larynx is subdivided into three components: one supraglottic, glottic, the vocal cord area, and subglottic. So disorders of these components produce a different kind of symptoms of the airway distress in the infant. If you have a supraglottic lesions, you can have a very coarse and inspiratory stridor. The glottic and the subglottic regions, whenever there is any obstruction, that can lead to a musical stridor and often a biphasic in nature. And if you have pure tracheal lesions, then usually they have a prolonged expiratory phase, and the expiratory stridor is similar to the case of the viral infections. The quality of the child's cry, the cry is either normal, it can be weak or aphonic, usually can suggest of involvement of the glottic lesion because of the glottic areas where the vocal cords will be there. However, if you have very severe subglottic narrowing, then that also can lead to abnormal cry because of the limited amount of the air movement to the subglottic area. So coming to the one of the important laryngeal pathologies, the first and the foremost that we need to discuss the laryngomalacia, because majority of the babies will have the laryngomalacia. The incidence is nearly 35 to 75% of the live births. It's also called as congenital flaccid larynx or congenital laryngeal stridor. It's the most common cause of the neonatal stridor is laryngomalacia. It happens because of the inward collapse of the soft, pliable supraglottic structures into the glottic area that lead to the stridor. So the true etiology is not known. Clinically, there are two distinct forms of this laryngomalacia. So one is a structural and non-neurological causes. So it's because of the structural abnormalities where we have a foreshortened tight area epiglotic folds causing the characteristic omega shape of the epiglottis, which can partially block the glottic inlet. Here, there can also be abundance of the supraarticular tissue that can collapse into the posterior glottic airway. The second thing is the neurological variant. There may not be a structural change as significant, but the neurological variant is because of the lack of the muscular tone that allows the prolapse of the airway. Clinically, these children also have certain neurological abnormalities. So here, the structure is not the main thing. There can be certain structural changes, but because of the lack of the muscle tone, your larynx is much pliable. Also, these babies usually have a certain amount of the gastroesophageal reflex, and in pathological reflexes can lead to more amount of the inflammation in the supraglottic airway, thereby increase the chance of the tissue retention and prolapse that can worsen the laryngomalacia. So any babies who are not responding to laryngomalacia, one should be much vigilant about the treating the GR. So sometimes certain 20 to 50% of the infants with severe laryngomalacia have certain associated synchronous airway lesions such as subglottic stenosis. So these should be thought of if the patient is not improving with the laryngomalacia treatment. Usually the most common symptom is stridor, but the cry should be usually normal until it's very severe laryngomalacia. So when the baby is getting agitated, that will lead to the exacerbation of the stridor. And if you keep the baby in the rest, especially in the prone position, the epiglottis will fall forward. That can lead to the relief of the airway, and the babies go to the sleep. Sometimes we not even listen the stridor also. They may present if the severe present at the birth, but usually present on 2 to 4 weeks, and they slowly progresses till 8 to 12 months with the complete resolution of by 2 years of age. If it is severe enough, that can lead to the difficulty in feeding because the baby need to manage both the respiratory and the feeding things. That can sometimes lead to the aspiration, that can lead to the gagging, that can lead to respiratory stress, that can lead to regurgitation, and that can finally lead to failure to thrive. In severe cases, there can be pectus excavatum. The baby can go into the apnea that can lead to the right heart stain and the corpus similar to the obstructive apneas. So we want to diagnose the laryngomalacia. When you have symptoms, we need to do a flexible laryngoscopy where you can see the omega-shaped epiglottis with the dynamic collapse. So this is one of the patient where we can see this omega-shaped epiglottis, which is, and also with thick area pneumatic fluid. We're not able to even see this vocal cords properly because of the so much of the collapse of this epiglottis and the upper airway into the glottic area. So if you think of any other secondary lesion along with the laryngoscopy, dactylaryngoscopy, we also need to the rigid bronchoscopy where you go beyond the glottic area, we can see the subglottic stenosis or certain things. So majority of the babies you might have seen, we say that if you keep the baby in prone position, if they are allowed to the grow over the period of time, the babies overcome the laryngomalacia, the tone will improve, and the laryngomalacia doesn't require treatment. For certain period of time where the babies have severe laryngomalacia that is affecting the baby's respiratory distress, requiring the prolonged support, may not improving the prone position, there is a failure of thrive, having apneas, then we go for a supraglottoplasty where we remove the excess of the supraarticular tissues and we release the epiglottic folds using the carbon dioxide lasers or cold instruments or microdebridement. Tracheostomy for the laryngomalacia is very, very rarely reserved, especially if you have any other significant obstruction after the supraglottoplasty or if you have any other associated lesions. So this is a treatment of laryngomalacia supraglottoplasty that we had in our baby. This is the baby had a very significant omega shape. These things after the supraglottis, after removing the retin tissues, after the epiglottic folds, now we can able to see the glottic area. We can see the vocal cords, and it's not obscuring this entry of the laryngeal inlet. After this, we have discharged the baby within a span of 1 or 2 days after the procedure has been done, and the oral feeds, and now the baby is on follow-up gaining weight. The next most common cause of this laryngeal abnormality is vocal cord paralysis. So what do you mean by vocal cord paralysis? Vocal cord paralysis is the inability of one or both the vocal cord to either abduct or adduct properly. This is the second most common cause of the stridor. Usually it is secondary to the rectal-laryngeal involvement. It can be usually unilateral, where the left side is more commonly affected right side because the long course of the left laryngeal, recurrent laryngeal nerve, and later it can be bilateral. So the causes of unilateral usually presents with the cough and choke during the feeding. They may not have a significant stride or retractions. Usually present with an aspiration like kind of things. Because the vocal cords are affected one side, they can be weak cry. Usually it is iatrogenic second to the traumatic delivery or it because of any post-operative surgery like a PDA ligation or post-ECMO where the bilateral is more, the right side is more common. The tough repair babies also have more chance for the vocal cord paralysis. And any mediastinal pathology can compress your recurrent laryngeal nerve on that side is the left side that can lead to this unilateral vocal cord palsy. The bilateral palsy is rare compared to unilateral palsies, where the babies usually have adduction that can be inspiratory stridor and any agitation or infection lead to the worsening and they can have significant airway obstruction. Usually, these babies have certain CNS abnormalities like anal chill malformations, cranial masses, and hydrocephalus. They need to be evaluated before taking care of this vocal cord palsies. So diagnosis radiography, when you see the unilateral vocal palsies can be associated with certain cardiac atrial enlargement because of secondary to some VSDs or some PDA that can lead to large amount of left atrial enlargement that can obstruct this recurrent palsies. There can be anomalous blood vessels that are actually causing the compression of the recurrent laryngeal nerve. Then you can see an X-ray, barium swallow, or an echo. We have seen one baby with abnormal aberrant subclavian artery that actually causes compression of the recurrent laryngeal palsies. That's leading to so much of the recurrent episodes of vomiting, and the baby was not able to gain the weight, and there was failure to throw along with the recurrent respiratory infections. When you do the barium swallow, we found that there is a certain impinging on the esophagus. Then we have done the CT angiography. Then it was shown that it's impinging on the esophagus and also the compression of the trachea. Then we need to do the operator and do the resection of that aberrant subclavian artery. After the baby gained weight well and they gone home within a span of 5 days. Now the baby is trying well. Those things can be missed with echo also. So keep an eye. We should be vigilant that if any baby who in this kind of symptoms, we can get a barium swallow. We can see that whether there's something is up causing the pressure on the trachea and the esophagus. So in absence of any traumatic delivery, in absence of any prolonged intubation or any cardiothoracic surgery or any TEF repairs, the course of the vagus should be investigated radiographically. MRI of brain, neck, and the chest may reveal a CNS lesions or mass effect on the mediastinal cervical noise. We need to do an awake fiberoptic laryngoscopy, sometimes necessary not to diagnose vocal cord palsies. We need to have video recording of these things so that we can discuss and have more details. So the bilateral palsy, because causing significant airway obstruction, may require the tracheostomy immediately. The bilateral vocal cord palsy can sometimes we can go the posterior cricoid split, we can do the partial chordectomy, or we can lateralization and suture it down, or we can induce the cricothyroid bottle injections so that they lead to the facility canalizations immediately after the tracheostomy. The unilateral palsy usually doesn't require tracheostomy because they don't cause an obstruction. They can be managed conservatively by keeping the baby in the sideline position on the affected side so that the affected will not, because of the gravity, move from the side of the obstruction. We can do the injection laryngomalacia in the oral children so that it can improve the feeding, voice protections, and also prevent aspirations. The new technique is a laryngeal innervation where they do the open surgeries, they do the microscopic nerve dissections, and then approximation are aimed to restore the function of larynx by utilizing the alternative nerves. So these are newer evolving treatment for this vocal cord palsy. It may not be there in all the hospitals. The next important thing is subglottic stenosis. What is subglottic stenosis? Subglottic stenosis is the narrowing of the upper airway between the vocal cords and the proximal trachea. And usually, majority of them it's acquired defect because of the prolonged intubation. Sometimes we found the babies having severe stridor, which is both expert stridor, that baby is not extubated, not intubated. Then we should think of the congenital stenosis. The congenital stenosis happens because of an abnormally shaped cricoiling. It can be elliptical rather than circular, or certain excessive amount of the subglottic tissue can happen that can lead to the subglottic stenosis. Congenital subglottic stenosis is diagnosed when the subglottic diameter is less than or equal to 4 mm in a full-term baby. The normal is 4.5 mm. Or if it is less than 3 mm in the premature baby, the normal lower limit is 3.5 mm. So less than 4, less than 3 mm in a term in the preterm baby, the subglottic diameter is there, then it is called as congenital subglottic stenosis. The mild form of the stenosis usually may not detect until 2 to 3 years of age. You might have seen the babies who come 2 to 3 years of age when they have repeated croup-like episodes after the respiratory symptoms. If the persistent attenuation when you do with an upper airway anomaly, then we find subglottic stenosis. In more severe cases, the biphasic stridor can present immediately after birth in the form of a classic croup. The cough will be there, but there won't be any signs of viral illness. The cry is usually normal because it is not a glottic area, only the stridor will be there. And the feeding is an issue in these areas because the babies will have a moment of a shortness of breath because of the airway compromise. So the five diagnosis, we need to do the direct laryngoscopy and the rigid bronchoscopy. So this we can see the subglottic area where you don't have a, you're not able to see any airway through, it's called subglottic stenosis. So we can also do the imaging studies like a CT scan where you identify the subglottic stenosis. The Cotton-Mayer classification of subglottic stenosis is most commonly used for assessing the severity. So the grade 1 where it is obstruction is still 50%, grade 2 is 51 to 70%, grade 3 is 71 to 91%, and grade 4 there are no detectable lumen will be there. The treatment you can do with the balloon dilatation or tracheostomy for emergency stabilizing where the significant area obstruction is there. In selective cases where there is mild to moderate, we can go with the anterior cricoid split with the consideration of graft that can prevent the tracheostomy up to 18 months of age. In more severe case of stenosis or an older child, then you can do the laryngeal reconstruction where you can take a rib for the augmentation of the narrowed part of the cricoid cortex. This is a treatment of choice in older children. The next is the laryngeal webs. So laryngeal webs are the congenital anomalies because of the incomplete canalization of the laryngeal inlet, which usually happens around 10 weeks of the gestation. So the baby can have a biphasic stridor, respiratory distress, aphonia. There are frequently associations of with the velocardiofacial syndromes and 22q11 deletion, that is a Diagnosis symptoms can be seen. So whenever we find this kind of thing anatally or postnatally, we can need to go for the fish, the genetic sequencing patient with an anterior to zoonotic webs. Again, we need to do the endoscopic evaluation. We need to assess the severity. The treatment of the laryngeal webs is the surgical excision, or you can go with the laser therapy. Then one of the tracheobronchomalacia may not be laryngeal, it's a bit lower, but we just, for the sake of a completion, we'll go with this also. The tracheobronchomalacia is the airway collapse, dynamic collapse in the trachea and the menstrual bronchi due to the weak cartilage structure. It can be primary, usually in the premature babies, bronchopulmonary dysplasia babies, where they can have a prolonged oxygen requirement, prolonged ventilation requirement. We usually don't do the bronchoscopy in these babies. If you go for the bronchoscopy, these babies may have a mild to moderate amount of tracheobronchomalacia. Because the prematurity itself is a risk factor for the more complex tracheal link with the lower tracheal muscle tone and your bronchopulmonary dysplasia use of in these babies, if you do more amount of the bronchial dilators, the babies will have the more amount of respiratory stress because it decreases the tone further. And next is the secondary tracheobronchomalacia, which usually happen the post-TEF repair because tracheofacial fistulas where your tracheoesophagus have fistulas, the connection with the trachea, they always have the weakest segment. Also, the vascular anomalies I said in previously can lead to the compression of the tracheobronchial tree that can lead to the malacia in these babies. So these babies can affect the stridor, wheeze, coughing, cyanosis, that can breath holding spells and difficulty feeding. We can misdiagnose a difficulty to control asthma. If we give this asthma medication, that can lead more amount of weakness and more amount of worsening. The cough must be ruled out, such as a laryngomalacia, foreign body aspiration, upper airway infection. These are the common things that once you rule out, then you go for a bronchoscopy, then you can tracheomalacia. The bronchoscopy and the dynamic aerology, you can see that is a, when you're going through the bronchomalacia, this is a tracheal ring, so there's a trachea, the tracheomalacia. So we can see that this is a dynamic thing with the video. We're not able to play the video. There's, you can see that airway space is getting narrowed because of this weak cartilage. So how do you manage? So mild TBM is self-limiting and usually involves as infant grow in the tracheal cartilage strength like premature baby bronchopulmonary dysplasia. This baby might require CPAP, chest physiotherapy, and any GRD also need to be artificially treated in these babies. So you can give the mucolytic agent in order to prevent the obstruction. Posterior pressure, sometimes even let's say tracheostomy if required prolonged period of time where we can have so that we can provide the good amount of posterior pressure. Iotopexy can be done if they can severe anterior tracheomalacia where you can attach your anterior trachea to the aorta or you can have this study. The next thing, subglottic hemangioma. Subglottic hemangioma is most common neoplasm in the infant airway and it can lead to the significant airway compromise. The lesions usually when you see it appears a smooth, eccentric, compressible mass in the subglottic area, most common located in the left posterior subglottic space. The lesion usually compared to any hemangioma grows postnatal for 18 to 12 months, proliferative phase, followed by slow but inevitable regression over the 5 to 8 years. They have a progressive biphasic stridor beginning around 4 to 6 weeks when they start, hemangioma start increasing. The fluctuant characters of symptoms is strong diagnosis of subglottic hemangioma. The stridor is worse with the crying or agitating because whenever there is a crying and agitation, the vascular engorgement of the hemangioma occurs. The cry is generally normal. You can get a CT scan where you see the asymmetric narrowing subglottic. The narrowing subglottic usually confirmed direct laryngoscopy with the direct rigid bronchoscopy. So we know that any hemangioma we are giving the propellant 2 mg per kg in 3 divided doses, but we should monitor for the hypotension, bradycardia, and hypoglycemia. We can do the surgical debulking or resections or laser therapy and pharmacological therapies are reserved for hemangiomas with airway symptoms that are refracted to the beta blocker therapy. In case of an extensive airway involvement, a tracheostomy provides a secure airway until the tumor involutes either by the therapy or because of the problem. Then we have the laryngeal clefts. Laryngeal clefts are the happen because of the failure of the midline formation of the tracheoesophageal septum. Usually the septum closes from the caudal to the cranial direction. The depth of the cleft is determined by the timing of the interruption. So Benjamin and England systems of classification type 1 varies the extent till the level of vocal cords. Type 2 is extend beyond the vocal cords into the posterior cricoid cartilage. Type 3 is beyond the posterior cricoid cartilage into the cervical trachea. Type 4 is beyond the thoracic trachea. So these are type 2 laryngeal cleft, but without extension into the cricoid cartilage. The type 3 laryngomalacia, where beyond the cricoid cartilage. So they can have 58 to 68% usual laryngeal cleft is also to other congenital anomalies. Most commonly is the digestive tract anomalies like esophageal atresia, TEF or TEF alone can be there. There can be cardiac, urogenital, and the craniofacial abnormalities. So there is certain charge syndrome, Wachtel syndrome, Palestral syndrome, Opitz-Fry syndrome. These all things can be associated with laryngeal cleft. Type 1 typhoid cases are managed endoscopically with the cleft edges are demucalized by the cold or laser techniques and sutures are placed. Type 2 typhoid require open surgeries where we need to interposition grafts are needed. And the Pierre Robin sequence is, that is a clinical triad of a micrognathia, retrognathia, glossoptosis, your tongue is falling back, and that led to airway obstruction. Most cases, there is a cleft palate. It usually occurs in 1 in 85,000 to 15,000 members. PRS has equal incidence between both the males and females and can be isolated as part of a larger syndrome. Most commonly present with very degree respiratory distress. The obstruction in PR is result of the posterior displacement of tongue, lead to narrowing of the oropharyngeal airway. Both the physical examine we can see and also we can do the laryngoscopy to exclude the extent of the obstruction. We can, based upon the severity, we know the things. We know that when they keep the baby in the prone position, the tongue will fall forward and can lead to the recurring obstruction. We can do the nasopharyngeal airway that can lead to the stenting. But if you are very severe, you need to do two kind of surgeries. One is a mandibular distraction osteogenesis and second is a lung tip adhesions. But when compared to both the mandibular distraction surgery, both are equal effective in preventing tracheostomy and restoring the oral feeding. But the thing is, mandibular distraction osteogenesis is a prolonged period of time. We need a second intervention in order to remove the device, and there can be more amount of complications like scarring, dental damage, and facial nerve injury. But compared to the tracheostomy, it prevent compared to lip tip surgeries, the MDO, that's the mandibular distraction osteogenesis, prevent the chance of tracheostomy much better than the tongue lip adhesions. The next and last thing is the congenital neck masses. So we can see certain type of neck masses that lead to the compromise of the airway. That can be lymphangiomas, teratomas are the most common airway lesions. So lymphangiomas are the lymphatic malformations where they are aggregation of interconnected dilated lymph vessels that most commonly occurs in the face and the neck. The lesions usually present in early childhood, most of them present at birth itself, and often involve the upper aerodigestive tract. The lymphatic malformations vary in sizes from very small to very massive, but certainly they can enlarge the size also and tend to grow as the patient grows also. Sometimes swellings, this can be controlled steroids, and certain times we need to eventually lead to the percutaneous drainage in order to prevent the airway. However, major lymphatic malformations require the surgical resections, or you can do the sclerotic agent injection that lead to the sclerosis of the lymphatic things. Teratomas are rare tumors where the consist of all three germ cells and can involve the head and neck in 5% of cases. Usually, we know that the teratomas are antenatal diagnosed based upon the prenatal ultrasonography. When they have been identified antenatally, we can involve the obstetric gynecology, anesthesia, neonatal, and otopharyngeal airways. If it is causing severe airway things, then we can go with the exit procedures so that we can intubate the baby and also do everything at the time. So, but when largely growing tumor that can lead to the hemorrhage, all of a sudden that can lead to the more amount of significant increase in compressed airway that can lead to the emergent airway management. Teratomas should be surgically resected. So these are all things that can airway. Certain times we can have very significant airway obstruction because of the teratoma, because of the congenital mass, or because of any other certain mass like cystic hygromas, where that can lead to the congenital higher airway obstruction, where the exit procedures is one of the more important things. So the exit technique is intrapartum therapy, where for performing the exit technique, we should have a detailed evaluation of the baby and a proper plan to be done. We should have an elective LSCS in these babies. The general anesthesia should be given for the mother in order to paralyze the mother. Even we can give the intramuscular fetal paralytics to the babies, and we can give the narcotics for the baby so that the baby will, it is very easy for her to have the intrapartum treatment. So just only the delivery of the head should be done. We should minimize the heat loss for the baby and also to decrease the interruption of the umbilical cord in order so that the baby still have the circulation and the oxygenation from the mother to the baby. Over the time, we can establish the airway. The airway can be established where by the intubation, where with tracheostomy, or where by the resection of the mass. We should complete all this in a framework of 60 minutes. And after we should deliver the baby of the body. So first we should have a rehearsal, we should have a clean explanation of the step-by-step things, and we should have a teams that should be allocated the things, and the team member should follow particular plan meticulously. We should have either one large room, operating room, where we can deliver mother, and side by side we can do the baby's things, or we can have a two small adjacent room. One room is for the deliver, second for the neonatal surgery if needed. The operating room is such that the maternal fetal medicine surgeon and the pediatric surgeon can work simultaneously. There should not be any delay, and in this way separation by the time we establish the fetal airway. The rapid sequential inhalation agents are used along with intravenous nitrile terbutaline to maintain the uterine relaxation so that the baby's body is still attached to the placenta in the utero. So this exit procedure that has been done for the baby of the neck mass. So you can see by the head is delivered, they have intubated the baby. So the prenatal evaluation, if you find by imaging, ultrasound and MRI, if you find the posterior neck mass without any upper airway compression, you can do the regular delivery. If you have any anterior or neck mass, or if you are anticipating any upper airway compression, having any laryngeal or tracheal anomalies where we need to establish the airway immediately, we need to have a proper prenatal counseling, involve the neonatologists, ENT doctors, pediatric surgeons, gastroenterologists, anesthetists, plan exit procedures. The exit procedures, airway management, if it is easily laryngeal visualized after giving the anesthesia, after the relaxants, immediately after the baby is delivered. If it is an easy laryngeal evaluation, before the direct laryngoscopy, ET endotracheal intubation should be done. We can use the ultrasound guidance also. If it is failed, or if you have a difficult laryngeal evaluation, then you can do the fiber optic endotracheal intubation under ultrasound guidance. If it is you're unable to visualize laryngeal anyway, then rigid bronchoscopy, and also can use the tracheostomy straightforward. So to conclude, the neonatals have a tremendous varieties of the case of the airway obstruction. Majority of the cases might be missed because of the lack of the availability of the direct laryngoscopy and the bronchoscopies. The familiarity with these different presentations, evaluation management strategies can help in salvaging these babies, and neonatologists quickly work toward the diagnosis and maximize the patient outcomes. And one should plan a proper exit procedure if you find anything in the future if that causes a severe compromise. Thank you.